Okay, welcome to Leadership and eHealth Change Management, Perspectives from Successful Hospitals Leaders. The Pan-Canadian Change Management Network is pleased to present the first in a series of change management webinars. Before we begin, I'd like to remind everybody on the phone line to press *6 to put your line on mute, and please don't put the teleconference on hold. My name is Barbara McCaffrey from Alberta's Physician Office System Program, and I'm hosting today with my fellow Pan-Canadian Change Management Network member, Cindy Hollister from Canada Health Infoway in Toronto. We're pleased to have 3 executive leaders presenting today from 2 Ontario hospitals that have undergone significant eHealth changes. We will be hearing shortly from Anne Trafford, VP Performance Information Management and CIO at St. Michael's Hospital in Toronto. From Ontario Shore Centre for Mental Health Sciences in Whitby, Ontario, we have Karim Mamdani, Deputy CEO, and Debra Churchill, Director, Clinical Information. The learning objectives for today's webinar are to identify organizational leadership features influencing change management in eHealth organizations. As well, we will make the connections between leadership and each of the 6 core elements of the National Change Management Framework that you will learn more about today. In today's webinar, before we get to the presentations by St. Michael's Hospital and Ontario Shores, we will briefly introduce you to Canada Health Infoway and put change management in the context of eHealth. You will also learn about the Pan-Canadian Change Management Network and the National Change Management Framework. To help put in context the eHealth change achieved by the 2 hospitals, a background on HIMSS stages will be provided before hearing from the executive leaders. A couple of housekeeping items for participants on the phone line today. If you've not done so already, please place your phone on mute by pressing *6 instead of using the mute button on your phone line. To ask a question, send a chat message to Clinical Adoption, the host in Toronto, by using the chat functionality at the top of your WebEx screen. The question and answer period will begin after both speakers have finished their presentations. Now, let's hear from Cindy in Toronto.
Thanks, Barbara, and both a good morning and good afternoon to those joining us from all over the country today. I'm Cindy Hollister, a nurse by background and a clinical leader with Canada Health Infoway's Clinical Adoption Team. Canada Health Infoway is a federally funded not-for-profit organization created in 2001 with a mission to foster and accelerate the development and adoption across Canada of electronic health information systems using compatible standards and communications technologies by building on existing initiatives and through collaborative relationships. So what is change management? In March 2011, a group of change management leaders working in the health IT space arrived at a consensus-based definition describing change management as a strategic and systematic approach that supports people and their organizations in the successful transition and adoption of electronic health solutions. The outcomes of effective eHealth change management activities include solution adoption by users and the realization of benefits. The Pan-Canadian Change Management Network, supported by Canada Health Infoway's Clinical Adoption Team, is a group of change management leaders and practitioners from across the country formed in 2009 that collaborates to communicate, educate, and share change management best practices. The network's vision is to be recognized as a leading national network for change management approaches and resources supporting successful adoption of eHealth solutions. The Pan-Canadian Change Management Network has developed an integrated national framework for describing change management activities within the context of eHealth projects It consists of these 6 core elements that you'll see before you: governance and leadership, stakeholder engagement, workflow analysis and integration, communications, and education, and last but not least, monitoring and evaluation. I won't describe these 6 core elements now because you'll be learning more about them from the executive leaders shortly, and toward the end of the webinar, we'll hear information about available change management resources. I am wanting to point out, though, that the focus of today's presentation is around governance and leadership. I am going to tell you a little bit more about HIMSS Stage 6, though, and what that means. And this is the Health Information Management and Systems Society, also known as HIMSS, Canadian EMR adoption model displaying measurement criteria for stages 0 through 7 of information and health and information and technology capabilities. At stage 0, you'll see that not even foundational systems are in place, but by the time all the criteria have been met for stage 1 through stage 7, a hospital has implemented electronic foundational systems, structured clinical documentation, and significant patient safety capabilities, including CPOE, clinical decision support systems, and closed-loop medication administration for patient care within the hospital, and is also capable of sharing data externally for continuity of care. So as you see in this 2012 third quarter report, there are no Canadian Stage 7 hospitals yet, and only 0.5% of the 638 reporting hospitals have achieved Stage 6. This percentage represents 4 hospitals in Canada who have experienced a high degree of e-health change. So who are these organizations? Canada's HIMSS Stage 6 hospitals are South Okanagan General Hospital, an 18-bed community hospital in Oliver, BC, and then in Ontario, North York General Hospital, a very large community hospital in north central Toronto, and today's featured organizations, St. Michael's Hospital in downtown Toronto, and Ontario Shores Centre for Mental Health Sciences in Whitby. And now I'll turn it over to our moderator, Barbara.
Thank you, Cindy. Just a reminder for everybody on the phone line, just in case you're not seeing the slides, there was a new link that was sent out very shortly before the teleconference began this morning. So make sure you've checked your email that you have the current link. So before we begin, just a reminder to everybody on the line, you can use the chat tool in WebEx to ask your questions throughout the presentation. Send your questions to Clinical Adoption, the host, and we will be compiling the questions and questioning the presenters when the Q&A portion begins. If your question is for a specific presenter, please indicate that in your question. We'll begin with Anne Trafford. Anne Trafford is Vice President, Performance Information Management and Chief Information Officer at St. Michael's Hospital in Toronto. As a member of the senior management team, Ms. Trafford helps to define St. Michael's information management strategy and ensure the hospital is at the leading edge of healthcare information management to enhance the delivery of safe, quality patient care. In the area of performance, Ms. Trafford further leverages on the synergies between IM, process redesign, and clinical care in the area of flow and from the perspectives of patients, data and reporting, and overall patient care improvement. So let's hear now from Ms. Trafford at St. Michael's Hospital in Toronto.
Good morning, good afternoon. Thanks for the introduction. Could we just do that again? Because I've never heard me described that way. Anyway, I'm pleased to share with you the experience that we've had at St. Michael's in our journey towards Stage 6. I'm going to start by, for those of you that aren't familiar with St. Mike's, and I think I'm going to have to ask Cassie to advance the slides. I don't seem to have control. So next slide, please. A little bit about St. Mike's. We are an academic health science center as was described earlier, we're smack dab in the middle of downtown Toronto, where it happens to be 14 degrees and sunny today, so I can gloat about that. That's probably the only thing I can gloat about in Toronto today. We're a fairly large hospital, about 475 inpatient beds. The typical smattering of services that you see in a large center, a very, very busy emergency department, significant ambulatory visits. And we deal with about 600 full-time physicians, which I'll speak to as we go through the presentation. Next slide. As mentioned, we're located at Yonge and Queen, right across from the Eaton Centre, for those of you that know Toronto. And I'm highlighting for you just some of the unique aspects of the care that we provide. Because we are located essentially in the inner city, we tend to have a very large, diverse, and needy population of patients. We have a high prevalence of patients with mental illness and addictions, socially isolated seniors. But then beside that, we tend to have many commuters and people from the business community as well. So we have a very diverse patient population, and that actually is reflected in the hospital's mission, values, our strategic plan, and the way that we actually approach all of our strategic initiatives. Next slide. In 2002, so I'm going to start by telling you a bit of a story, because I think really to understand change management, you have to understand the journey and the experiential role that time plays in leading change. So for our hospital, it all started in 2002 with the first ever IM strategic plan for St. Michael's. And that set the stage quite clearly with a vision for an integrated clinical information system. The hospital was clearly committed to moving forward to be a state-of-the-art in terms of the use of health IT. And at the time, they coined the project in implementing the electronic patient record to be called Gemini. And that was to represent the twinning of transformation with technology. And that really set the stage, and to this day, we still talk about Project Gemini. However, 2002 was a bit of a challenge for the organization as the project kicked off. Shortly thereafter, SARS hit in the spring of 2003. And I think the reality of an organization undertaking a large-scale transformation and technology project started to be realized. So there were many, many, many challenges in the project. The original timeline, as developed by the vendor, was very unrealistic in terms of the pace of change and actually the readiness of the application itself. So there were the typical business case IMIT project issues. There were delivery delays with the vendor. There was problems with the software. It wasn't robust, it wasn't mature, and it wasn't meeting the needs of our academic clinicians. We had issues with Canadianization. And of course, all of this led to issues with clinicians' lack of acceptance, significant change management challenges across all aspects of the organization. And in the end, really, the project suffered from credibility, and there was real lack of stability. So change itself and these journeys with electronic patient records, I think, have to be understood to be long, slow processes in some ways. And I'm going to tell you about the early days, and I'm going to tell you how that actually set the stage for us to essentially leap forward later in our project. Next slide. So this is actually one of the change toolkits that we used very early on. So you can see it's from 2006. The blue lines represent the unique logins to our legacy system, and the purple represents the unique logins to the new system. So as you can see, in 2006, we had a significant issue with our clinicians actually adopting the new system. We used this kind of scorecard in two ways. We used it as a benchmark for the IMIT team to understand how we were progressing with the project. And eventually, throughout the project, we used it as an incentive to actually start to push people towards using the new system, which I'll explain in the next slide. So things were, the project had been going on for about 3 years, and the executive team at the hospital realized that it was time to really rethink our strategy. And they had the courage to say, We're still committed to our vision. We believe we're on the right path, but we need to stop and really think about how we're going about achieving the transformation, because our current pathway quite clearly is not getting us to where we need to go. Next slide. So we developed at the time our own sort of adoption/change management framework, and we focused on 4 key things. We said to our clinicians and our users throughout the hospital that we will work with them in partnership. So there was a fundamental philosophical shift in the hospital to move the project from an IT-driven one to a clinically driven one. And that meant that the values of the project team shifted as well. And the focus was ensuring that we deliver value to the clinicians. So simple things like in the original implementation, historical data had only been converted for 2 years, and the clinicians wanted more historical data converted because there wasn't enough value in the new system for them. Delivery. We committed to delivering on time, or if not on time, to not delivering until the functionality and the robustness of the application would meet the clinical needs. So we committed to a safe, stable delivery. And in fact, because we were a bit of an alpha site for the software we were implementing, we actually created something called the stability clock. And what that meant was for our clinicians, if we, as we were using the system, if we encountered an issue with performance, with response time, with functionality, we would, as we said, stop the clock, fix the problem, restart the clock again, and we would not take away our legacy system until that stability clock had been stable for 6 months. That actually worked well for us. We only reset the clock once, but it did actually allow us to send a message to the organization that we were committed and secure in our approach of ensuring that we delivered a safe and effective system. We also looked at innovation. So where we knew we had a long journey to get to the end point of an electronic patient record, we understood that along the way we may have to take little side trips and build things that were of clinical significance that perhaps weren't on our original roadmap. And that's what I refer to under the 2 bullets of innovation and partnerships. Next slide. So surprisingly enough, on March 2007, March 31st, 2007, at 23:59, we actually sunset our legacy application. One of our ED docs was the very last person to log in to the system, and he wears a little badge of honor about that to this day. And that really set the stage for us to move much more quickly at a much more rapid pace and develop and deliver enhanced applications to our teams. So if you look at the next slide, this is, in a nutshell, our journey end to end, the sequence with which we brought up different types of technology. And if you look at the slide, starting from our kickoff in 03, the early days between 03 and 07, there was not a lot delivered to the organization. We had our foundational systems, risk packs, scheduling, traditional order entry. So it really was from 07 forward that we started to move quite quickly. And in each of those years, we delivered significant transformational applications to the organization. And we did it because we had commitment. So if you go to the next slide now, we had an executive steering committee. And in the earlier days of the project, that steering committee consisted of the CEO, our chief administrative officer, chief nurse, chief medical officer, the CIO. Of course, we always have the finance person at the table, our chief medical information officer, and the chair of our MAC. That group met weekly for about 3 years. Once the project was stable, it moved to biweekly, and to this day, it still continues to meet on a monthly basis. As we were progressing through our roadmap, we brought professional practice, pharmacy, and other leadership to this particular table, depending on the phase of the project that we were implementing. So the executive leadership was critical for us. The project was on everybody's corporate objectives, cascaded from the board right through to every single one of the managers in the organization. We also had a great structure within our own IM team. providing the opportunity for the leadership team to have quiet conversations off the record to strategize about particular challenges. And again, to this day, we continue to meet on Fridays at 8 o'clock to deal with ongoing issues with respect to the rollout of systems. And we had the traditional project structure, which I'll talk about a little bit later. Next slide. I think one of the foundational elements of our change strategy that we did well and that I would do again was we did a comprehensive stakeholder analysis before launching some of the more robust clinical applications. We did a map essentially of all of the leaders, all of the physicians across the organization, and looked at their capabilities in terms of whether or not they would be a change champion for us or a potential resistor. We then aligned our governance model to make sure that we populated the different levels of the project with diverse stakeholders so that we would be getting a comprehensive opinion from our user community. And we also put a process in place whereby once we'd identified our champions, we created a distributed leadership structure so that, for example, order set development for our CPOE project was actually owned by each of the services, and our project team was an enabler to support the process, but not the owner of the process. And this meant that we had support from the executive team to provide the resources to the organization to get the work done, and that included stipends for physicians, backfilling of staff, and support for Go Live. Next slide. I'm not going to go through this eye chart in detail, but this is just one of the structures that we had for one of the projects that has been implemented in our journey. It was the last big one. We've been live now for, I can't even remember now, about 14 months with our computerized practitioner order entry and electronic medication system. And the slide, I think, just is a good graphical representation of the fact that it takes a village to implement these complex systems, and that it takes strong governance to make sure that the decisions are made at the appropriate level. Next slide. In terms of communications, what we did learn was we needed to tailor our messages at each level of the organization. And in fact, now we've actually matured enough that as a standard within each of our projects, we have a communications plan that's mapped to the phases of change management. We've adopted the Cotter model across the organization, and we use that to actually demonstrate the phases of our project, ensure that the phases of change are contemplated in each of the major projects. We used formal and informal forums, and I have to say fireside chats ended up being one of the best mechanisms we had for communicating, creating two-way paths. We had lots of successes, lunch, dinner. We did find, as typically organizations do, that providing pizza is a good way to incite input from clinicians. Next slide, please. And we had the typical education and training approach. We learned early on that blended learning was the best way to deliver these complex clinical systems. And I think one of the things that we did well is, was to provide funding for on-unit support for 24/7 times whatever number of weeks we felt the unit was going to need, depending on its level of maturity and engagement. And we also learned that we needed to look holistically at the change and not forget our support departments. Next slide. To sort of wrap up in the next two slides, I think from our perspective at St. Mike's, as I've mentioned before, we learned that these are systemic clinical initiatives, not IT projects, and that visible leadership at a clinical level is the critical point. A leadership that will have the courage to address practice changes, for example, looking at the interplay between pharmacy and physicians and how those roles can support and enable each other, and the courage to move towards more standardization. Next slide. And in closing, again, thanking you for the opportunity to share our journey. Really, the key success factors that we've learned are that it's best to make change management a guiding principle in all of your projects. Ensure that your leadership and project team understand the principles of change. I recall, for example, when I first started as the CIO in 2005, I used to have these chats with our chief medical officer, and for the first 18 months he used to say to me, "What is change management, Anne?" And today, He's walking around the hallway with copies of the Cotter book under his arm as a key advocate and leader in change. Be transparent about your challenges. Leverage all the levels of the leadership team that you can throughout the organization. And the one point I would add that's not on the slide is make sure you're thinking about how you're going to sustain the change, because these are hard projects to achieve. And once you've achieved your outcomes, you want to make sure you sustain the investment. Thank you very much. I'll turn it back over to you.
Thanks, Anne. That was wonderful. And for everybody on the line, if you have a question for Anne, please use the chat functionality to send your question to the clinical adoption host, and we'll be getting to those after Ontario Shores. So I'd like to welcome Debra Churchill and Karim Mamdani from Ontario Shores. Ms. Churchill, as Director of Clinical Information, is the project lead for the implementation of Ontario Shores' fully integrated electronic health record system. As the co-chair of the Interprofessional Practice Advisory Committee, she has worked collaboratively with the professional practice leaders to enable the integration of interprofessional care and practice at Ontario Shores. Ms. Churchill is also a faculty advisor in the Faculty of Health Sciences at the University of Ontario Institute of Technology. Karim Mamdani is the Deputy CEO at Ontario Shores Centre for Mental Health Sciences. His areas of focus include labor relations, employee engagement, financial and operational management, accountability, land and building development, funding systems, and strategic operations planning. Let's go now to the team at Ontario Shores.
Thanks very much, Barbara. I appreciate the introduction, and again, good morning and good afternoon wherever you are across the country. So it's my pleasure to talk a little bit about Ontario Shores and to provide context for our journey. And I'm having the same issue that Anne was having and cannot advance the slides. So I'm wondering if I could ask you to go ahead, please, and advance the next slide. Okay. So the Ontario Shores is a teaching hospital specializing in comprehensive mental health care. We have 1,200 employees, a large inpatient population of 339 beds. We follow about 3,000 outpatients. And particularly in respect to mental health and addictions, this is a chronic condition, and the care that we provide spans a continuum, which includes a number of our partners. And so the patients, their families, other partners in the community are all part of our delivery model. And we also span the life cycle of an individual from adolescence to seniors. Next slide, please. When we get to our program clusters, our area of specializations, we've identified three: forensics, geriatric mental health, and adolescence. The other service areas, because it's never just about a particular diagnosis or particular program, we also have patients who arrive with a variety of comorbidities associated with medical interventions that are required. And so we provide services in metabolic, outpatient ECT, dental services, and other primary care services. Next slide. So when we think about our adoption and change management roadmap, we really look at the ability of a very large degree of work that we did around readiness and pre-work. That readiness and pre-work was making sure that we were ready, that our clinicians were ready, that we had our forms ready. So I would recommend that as part of any of your work, you spend a fair amount of time on the pre-work before you actually launch a project of this nature. We also looked at planning resources and allocation and all of those things that you would normally do from a project management point of view, and that looks at charter sign-offs and things like that. The technical infrastructure and devices was a key enabler for us. We did not have an infrastructure that was ready to support an electronic health record, so we ended up spending a great deal of resources on the hardware to support, if you will, the infrastructure, the actual documentation that we needed to do. The application and design and build and test, of course, you would all be familiar with that once we started to get into the build. Very proud of our team. Our team did a fabulous job on the build and testing environment. This was something that we took on as opposed to trying to bring consultants to actually do that for us. And then end user education, and again, you can imagine how important that is. I think Anne spoke to that as well. So we achieved HIMSS 6, but I think it was more a byproduct, really, of the work that we did as opposed to a specific goal that we had in mind. And so I think that if you looked at each of those small bullets, you'd appreciate that it was a building phase. I'll turn it over to Debra to take us through the next few slides.
Great. Hello, everyone, and thank you, Karim. And so what you're seeing here now is, again, our focus in order to help us achieve what was important. But this is a part of a change management strategy. You have to have decided this going into it. And so these bullets here should not be unfamiliar to anyone. Looking at safety and quality, making sure we have an integrated evidence-based content that uses standards. We also took the opportunity as an organization to use this to enable our new culture of care, and we had moved to a more recovery-based approach to care, and so this was a great opportunity for that to happen. The use of our EHR focused on accountability and transparency, and those of you who use the system know that now information is being shared. It's not hidden in a binder on a shelf, that all of our documentation, care planning, and assessments are readily available for all. Your success factors are often most measured, though, when you can then start to take that information and use it to support clinical outcomes and decision-making. Sorry, thank you. And I think the other key for us was using our documentation and using our EHR to really bring our teams together, not only just in the build and design, but in as we used it. And so now that they're using it to enable their practice and promote good communication practice and care delivery. So we can have the next slide now, please. So, there we go. So managing change, and I think Anne did a great job of kind of outlining for everyone the steps that are so important. But really, one of the key enablers for us was that we always identified this as a clinical project, right, from readiness to current state to future state. And the fact that it was a clinical project really allowed us to get the leverage that was really being supported through our senior team, directors, and our stakeholders. And so our structures were key in using our clinical informatics team, our professional practice team, our interprofessional team, alignment with decision support, IT, our health records management, quality, risk, and patient safety, and our clinical programs. And our governance structure, which we didn't include for today's presentation, would identify how we had membership and ownership involvement in all those various areas. And I think that the committee structures were extremely helpful for us because they allowed us to be open and responsive to not only the building of the system, but on the ongoing monitoring and managing. It also assisted us in developing and building capacity and sustainability internally in those various programs and areas so that we would be able to support the continued development of our system. In order to be very effective in that, we also use the very key project management processes, charters, work plans, etc. You can have the next slide now, please. I think that the whole intent, and as Karim mentioned, was that we sort of realized about a third of the way into our project, because we did this over a 30-month period of time. And so as you're developing, building, and growing through the phases, you suddenly begin to realize that you're meeting certain criteria. And I think when we took a look at the criteria that were required, then we suddenly recognized by the time we were finishing up our outpatient areas that we were meeting the criteria for a stage 6. But I think these elements that support integration, clinical quality, clinical benefits, clinical decision support tools, safety, structured documentation, and system quality are really where you start to get the bang for your buck. And some examples for us at Ontario Shores, we have 90% of all physician admission histories are now using the recommended template. That was designed, developed, and implemented by our physician champion team. We have 87% of our physicians using the SOAPy format in their progress notes now, which really allows for a lot of clarity when you're trying to sift through notes. We have 96% of all of our orders are entered into the system directly by the ordering provider, be a physician or nurse practitioner. Another great example for us is we have 93% of all of our medication administrations are now being scanned versus being manually documented. There's some examples as you start introducing the changes to be able to go back and ensure that what you are doing is actually being used and is having some effectiveness. Have the next slide, please. And so I think you don't spend very much time relaxing and enjoying, what you have just completed, because as we have learned, and as many of you already know, an electronic health record is a dynamic, viable, living system. And so we're always managing and monitoring and protecting it and building it and growing it on a daily basis. But as we look to our future, it's good to have a very clear framework in place to help you identify that you've got your focus on where it needs to be. And so you want to always ensure that your high-tech supports high-touch and high-quality care. And so key for us now is looking at satisfaction and productivity. So we're continually monitoring our staff using our system. Are they accessing it correctly? Is it being navigated in a way that makes sense to them, or is it causing them some concerns around that? Patient satisfaction, we are moving into looking at now and implementing a patient portal, and so we're really going to be very considerate of the impacts it will have on their care. And I think the other key factor that's becoming evident in a bit of the literature that we're seeing is, does our EHR have a negative impact on the time that clinicians are spending with patients, and how do patients perceive that? Around the areas of quality, I think it's important that we're very clear to ensure that our system is always enabling and supporting quality care and supporting professional practice and their accountability. And so taking a look now at the timeliness of care and documentation is one of and some of the outcome measures that we're now looking at as far as use of the system. And the clinical relevance of the documentation, of course, is now much easier to focus on due to the accountability and transparency that's in the system. And I think we're our access, we're taking a look, as I mentioned, at patient portal and our evaluation of devices. But another key area for us in access that we have discovered was the integration of our outpatients and inpatients. And as Karim mentioned, our patients, because of the chronicity of mental health and mental illness, patients often move back and forth between outpatient to inpatient and various community providers. And I think for us, one of the key benefits around access was certainly the ability for outpatient clinic information to be readily available and centrally located rather than scattered across a very broad geographic area. So that would be one of the key points that I would want to bring as far as evaluation, and we're just about to start measuring and monitoring some of the evaluations of our outpatient and ambulatory care areas.
So let me then talk a little bit about some of our success factors. One of those was the leadership, in fact, provided by our board. We, as a senior team, worked very closely with the board, made sure that, in fact, they appreciated how this particular project was aligned with the strategic directions of the organization and connected to our mission, vision, and values. That engagement paid dividends because it really required their leadership, the board's leadership, in resource allocation and in thoughtfulness around the vision that we wanted to get to, and then really allowing management to pursue that vision. The collaboration and promotion was quite evident, as you'd have heard from Debra's presentation. We've paid a great deal of attention to that across the organization. We celebrated, and we did that often. Whenever we had an opportunity, stage 1A of phase A, we celebrated. 1B of phase 1, we celebrated, and so on. I think it was important because each one of those celebrations woke the organization up to the journey that we were on and the progress we were making. There's a great deal of discipline and accountability associated with a project of this nature. All of us were committed to it. You've often heard about the triple aim. the triple aim for this project was on time, on budget, and on functionality. And at the end of the day, we achieved all three of those particular legs to the stool. Next slide, please. So at the end of the day, we acknowledge and greatly appreciate the success that's come our way on this. But really what it's about has been a tool that allows timely documentation, the fact that it has effective use by our clinicians, that it's seamless, and that it's geared towards our patients and their needs. And the fact that we achieved that, I think, has led to all of the other acknowledgement. So I'll stop there, turn it over to you, perhaps, Barbara, for the next set of comments.
Thanks, Karim and Debra. Really appreciate that. Again, for everybody on the line, you can use the chat functionality to send your questions to Clinical Adoption, our host, and we will get to your questions. Our first question is going to be for Anne Trafford. And it's very interesting today. We have two hospital-type organizations. St. Michael's did their change over a long period of time, and Ontario Shores was very short, being 30 months. But St. Michael's is so large that you do have a family practice clinic within the hospital, and I know we have some EMR groups on the line. And how did you apply the lessons learned from the large clinical change initiative at St. Michael's Hospital to your recent EMR implementation within St. Michael's at the family practice unit?
Oh, good question. And it started by buying flak jackets for everybody on the project team. And interestingly enough, our EMR implementation was really fast and quick. So we obviously gained momentum as we gained experience. I'd say really what we did was know enough that the selection of the EMR actual application needed to be clinically driven. So my team within the IM portfolio supported and facilitated the procurement process, but made sure that our physicians and the multidisciplinary team were actually critically evaluating the functionality. We played a role in helping them understand how it would impact their workflow, but they really, at the end of the day, made the decision with our support. So that was sort of setting the stage, number one. And we had a physician lead for the EMR implementation. It was physician-driven. There was a physician steering committee. As the CIO, there was very little I had to do to guide that group. Occasionally I had to ask key questions to get them thinking about the implication of some of their decisions. But by and large, they really, as a leadership team, drove it. We also recognized early on that the demographics in our family health practice from a physician perspective are quite varied and, in fact, fairly bookended at different ends of the age spectrum. So the physicians themselves recognized the need to allow multiple options for physicians to bring on the functionality, adapt it within their practices. They allowed for different tools, different electronic tools, and different levels of support to actually help with the migration. And we used the same principles around deliver and value, so the lab interface went first before we expected their CPP, et cetera. And actually we had a presentation at our quality committee of the board this morning from one of the family health docs outlining all of the quality initiatives that they're now able to support because they've got such good adoption of their EMR.
Oh, that's great to hear. They are an excellent tool for quality improvement. Thank you, Anne. Our next question is for Ontario Shores. With the importance of leaders providing messages throughout the project about the evaluation and monitoring process, what types of messages should they be communicating?
Hi, it's Debra. I'll jump in and as far as the messages for communicating around evaluation, what we did is we tried to keep that, again, the evaluation as close to the user as we possibly could, particularly in the beginning. So that was allowing the opportunity for our users to be engaged in the auditing process of how well they were using the system. We did not focus on clinical relevancy in the beginning, but we really focused on creating a framework together of the elements of documentation and that we wanted to ensure were being used. which also allowed us to evaluate how well they were navigating the system and using all of the various areas of functionality that they had asked to have had built and developed. And so that was a key in favor of that. Also helped in the change management. The other piece was because it was interprofessional in nature, we really used our professional practice leads to help with that level of auditing. Then when you want to start looking at evaluation and monitoring of use of the system, that was a little far removed from our clinicians, and that was some of the work that was done through our clinical analysts and the people who support the application.
Pardon?
Sorry.
Oh, can we ask participants to put their line on mute, please? Thank you.
Okay. So we started with some of that messaging close to the users. The second area of auditing and evaluation was coming more from the system use, and now we're moving it out yet another level and going to start to be more focused on specific areas of evaluation and monitoring around such clinical practices. For us, as example, would be use of restraint and seclusion, use of levels of clinical monitoring, how we're using it now to measure our ability to assess and implement care plans around falls risk, choking risk, etc. So we've used our evaluation and monitoring at different levels based on the framework and based on the needs of the organization.
Thank you, Deborah. Very good answer for a complicated area. Another question for Ontario Shores. In large change initiatives, what role do leaders play to influencing sustaining the changes, or in other words, making those changes stick?
Thanks, Barbara. Maybe I'll try that one. I think there's two legs to that. The first is around governance and making sure, again, that you're checking in frequently with the board, that they are focused on the organizational strategy, safety, the patient, so that overall we remain focused on the reason for being. And then, if you will, for the senior management team, it's this frequent check-in as well. We initially started not as often as Anne and her team, but probably meeting on a monthly basis, specifically on the project, and have remained connected to it. The senior management team also has to be prepared to roll up, our sleeves and really get immersed into the project. And that means really paying attention to the cues and the questions that are coming from the team, and being honest about understanding the challenges that they're facing, both from a resource perspective, et cetera. You also have to pay a lot of attention around building your teams. We spent a huge amount of time figuring out who were going to take the leadership positions as the team rolled around, and we made sure that people could work with each other, that there was a collaborative nature, and that you sustain that collaborative nature as you go forward. That's something that you have to pay particular attention to. You have to remain committed. As we've said previously, once the project itself is done, you can't just say, well, okay, the project's done, let's move on. You have to remain committed to that project. You have to make sure that resources remain in place and that project management remains in place. It can't be isolated. You can't just do a project. You have to do a number of other things to support the project, which includes, changing processes, being complementary goals and objectives within the organization. Debra mentioned some of the other ones that we're pursuing now from a clinical nature, like seclusion and restraints, but they have to fold into how we're going to be working with the information system. And lastly, continue to be bold. This is hard work, and people are quite bold when they set out to do this work. And I think keeping that sense of innovation and keeping that sense of courage as you take the next step and not losing that, I think, is also part of that sustainability.
Thanks, Karim. That's a lot of information. And we're going to go back to Anne. There's a question that came in. You noted that newsletters were not very successful when you were communicating the change at your organization. Can you elaborate on that? These are sometimes a preferred method by some managers, and a participant on the line would like to better counsel her manager.
Okay, so I see the difficulty we had with newsletters was, A, producing them and turning them around in a timely manner. So they ended up being a vehicle to showcase success rather than really communicate the specific tactical details around the change that we needed to get to each unit in preparation for their experience of the change. So if you look at communications and a multimodal strategy, you do need a way to profile, celebrate, and communicate to the broad hospital community. And a newsletter can do that, but it's often a retrospective perspective on the project. What we really found we needed to focus on was getting messages out in a timely way, just-in-time communication to the frontline staff as they were preparing for the change and as they were experiencing the change. Newsletters just weren't effective for us, even in sort of forecasting to units that hadn't yet been implemented. So we ended up using on-unit huddles. One of the best interventions we had was simply putting up a chart in each of the nursing units and allowing staff to write their comments and questions about the change, and then my team would go around and write the answers and collect the comments and questions. So depending on what your particular communication objective is, the newsletter may be effective, but it certainly isn't the quick hit, tactical, detailed vehicle that in this organization.
So you were able to provide real-time feedback to those with the questions.
We needed to, because the change, for example, with the CPOE and electronic medication administration, the change is so complex to the whole clinical ecosystem that you actually don't have the time to not provide it an answer right away, because sometimes a clinical decision is waiting on the answer.
Thank you. That's a critical element. Another question for Ontario Shores. Without using the word middle manager, you did touch on middle managers, and studies do show that they play a key role in change management initiatives after executive visible sponsorship activities. Can you provide some lessons learned about the importance of middle managers at Ontario Shores during your change?
Oh, absolutely, and I guess if we had addressed our lessons learned, that would have been one of the key. During our implementation and go live, we engaged our managers every day. We did a huddle at the end of the day, 15 minutes, and we invited every manager to come and be a part of that. And that's when we heard that just-in-time feedback about what was happening. But I will tell you that that was one of the areas in going forward where we probably dropped the ball, and we've had to pick it back up again. And that is to ensure that you have that's where the rubber hits the road as far as making sure staff are utilizing the system. And they're usually the folks to get the first level of feedback if there's a problem or a concern. And so we've really been focusing heavily on engaging the units and the managers at their level. And that doesn't happen as readily as it needs to through our committee structures. And so we have sort of used other methods for making that happen. And that's through unit visits, through staff meetings, et cetera. And really taking, rather than having the managers come to us, the strategy that we're rolling out now is we're having our informatics team go to them. And one of the things we're also doing right now is setting up a web page, an intranet web page that's going to allow for communications from managers and or staff back and forth directly so that we can kind of have some real-time chat rooms set up to help answer questions. But I think the role for our frontline managers is absolutely key, and it's key in helping them to support them. Number one, that they know how and understand to use the system. They don't have to be expert users, but it certainly is in their favor and in your change favor if you've got managers who are at least comfortable in addressing a question or knowing who to reach out to get an answer for one of their staff. And that was one of our lessons learned, and it's something we have to make sure we don't let them drop off our radar.
Okay, thanks, Debra. We're going to go to the last question, and this is going to be for Karim. Karim, you mentioned a triple aim focus. Can you expand on that?
Sure. I mean, I was using that very much as a comparator. Those of you who are familiar with the IHI models will know that Don Burbick and others have spoken about a triple aim approach to healthcare. We used a the same, if you will, set of words to talk about our project in terms of on time, on budget, and being on function. And, oftentimes people will say, well, you can have two of those, but you can't have the third one. And we took the approach that, no, you know what, it's three legs of a stool, and we have to achieve all three of them. And so, that's where you sort of had everybody on deck. We had long conversations when we ran into a challenge around either budget or function, and talked about how can we innovate out of that? What is it that we can do different? Is there something that we can learn from somebody else who's doing this? And mind you, we were one of the first ones, but somebody in the States, if they were doing a 6.0 implementation, is there something we could learn from them? So it was this constant search for a way to get through that problem rather than to accept that we would have to give up one of those three legs of the stool.
Okay. Thanks, Karim. And as we're summing up here, I wanted to thank the three of you very much for your presentations and sharing your wisdom and lessons learned with us today. I think that as far as the National Change Management Framework goes, you touched on all 6 elements of the framework. One message that I heard really loud and clear was that importance of communications at every level of the organization. I would like to, in conclusion, as we move forward, thank on behalf of the Pan-Canadian Change Management Network, Anne, Karim, and Debra, for sharing their knowledge and experiences with us today. Now, for participants on the line, for more information on the Change Management Framework and to explore the Toolkit repository, visit the Change Management Forum at the Canada Health Infoway website. I'd like to thank all attendees on the line today, and also to inform you that you will receive an email with a link to a short evaluation form, and we would really greatly appreciate it if you would complete that and fill it out. So thanks on behalf of everybody at the Pan-Canadian Change Management Network. We'll wish you a good afternoon or a good morning if you're on the West Coast with us. So have a great day, and thank you.